Hello guys. So am I audible? Am I audible or visible? I guess I'm audible and visible. So today we are going to talk about the physical examination. Okay. So let's start. So our sir has have given a book which is called the Lynn S. Bickley Bates Guide to the wait, I'll tell you. It's called the Bates Guide to Physical Examination and History Taking. Okay, it's a 12th edition book. So, so he told us to learn from what he had like markings. Okay, so so what did he tell us? He told us to review the history and physical examination, comprehensive or focused information. Okay, so comprehensive assessment is basically is appropriate for new patients in the office or hospital. Provides fundamental and personalized knowledge about the patient. Strengthen the clinician patient relationship, helps identify to or rule out physical causes related to patient concerns, provides a baseline for future assessments, creates a platform for health promotion through education and counseling, develop, develop proficiency in the essential skills of the physical examination, and focus assessment is appropriate for established patients, especially during routine or urgent care visits, addresses focus concerns or symptoms, assess symptoms restricted to a specific body system, applies examination methods relevant to assessing the concern or problem as thoroughly and carefully as possible. Okay. So what are these two types of first is the comprehensive, second is focused. Okay, so comprehensive means full, like we ask the patient like full history of the disease, from when did you get this disease, what is do you have any family history of this disease, and all the stuff that we need to know about the disease. Okay, that's called the comprehensive assessment. Okay, and focus means like okay, so if a patient comes to me and he he has a back pain. Okay, back pain. Okay, so I would ask only about the back. Okay, I won't ask about the any other symptom like a chest pain or leg pain. I will ask about only back. Okay, so that is a focus assessment. Like we should focus on the treatment of that particular organ only. Okay, so this is the difference between the comprehensive and focus. Okay, so naturally the we use a focus assessment for the established patients, like the patients who visit us daily, not daily, but monthly, weekly, okay. And comprehensive means like a first time visit, like the patient is new, we don't know anything about the patient. So then we can take all the information of the patient and diagnose it and treat it. Okay, now okay, difference between the subjective and objective data. Okay, so subjective data is what the patient tells you. So, for example, a patient comes to your clinic and he's complaining about the headache. Okay, so do you know that? So can you calculate the authenticity of the headache? Like is the patient actually having the headache? Okay, you can't. Okay, you just trust on the patient information given to you. Okay, that's called the subjective data. It is basically what patient tells you. Okay, then the symptom and history from chief complement through review of systems. Okay. Example are Mr. G is a 54-year-old hairdresser who reports pressure over her left chest like an elephant sitting there, which goes into her left neck and arm. And objective data, what is objective data? So what you detect during the examination, laboratory information and test data, all physical examination findings or signs. Okay. So what is the difference between subjective and objective? Subjective is basically the it is in relation with the patient. Okay, and objective is basically the signs and symptoms which we can see, which we can measure by our own hand, or by uh, or by our own eyes. Okay, example is BP. We can measure the BP. Okay, we can feel the patient's skin, right? Okay. So that's just the thing. Components of adult health history. Identifying data such as gender, age, occupation, martial status. Source of it history. Usually the patient, but can be a family member or friend, letter of referral, or the clinical record. If appropriate, establish the source of referral because a written report may be needed. Reliability varies according to the patient memory, trust, and mood. Okay. Chief complaints: the one or more symptoms or concerns causing the patient to seek care. Present illness amplifies the chief complaint, describes how each symptom developed, includes patient's thoughts and feelings about the illness, pulls in relevant portions of the review of systems called pertinent positive and negatives, may include medications, allergies, and tobacco use and alcohol, which are frequently pertinent to the present illness. Past history lists childhood illness and lists adult illness with dates or for events in at least four categories: medical, surgical, obstetric or gynecologic, and psychiatric. Includes health maintenance practices such as immunization, screening tests, lifestyle issues, and home safety. Family history outlines or diagrams age and health, or age and cause of death, or sibling, parents, and grandparents. Document presence of documents presence or absence of a specific illness in family, such as hypertension, diabetes, or type of cancer. Personal and social history describes educational level, family of origin, current household, personal interest, and lifestyle. Review of systems documents presence or absence of common symptoms related to each of the major body systems. Sorry. Okay. So sir also told to memorize the attributes of a symptom. So first, location. Where do you feel the pain? That is the main cause. Okay. Quality. Like rate this pain from 1 to 10. Okay. And quantity or severity. Then timing, including onset, duration, and frequency, the setting of in which it occurs, and factors that have aggravated or relieved the symptom, and can and associated manifestations. It is also important to query the pertinent positive and pertinent negatives drawn from sections of the review of systems that are relevant to the chief complaints. The presence or absence of these additional symptoms helps to generate the differential diagnosis, which includes the most likely and at times the most serious diagnosis, even if less likely, which could explain the patient's condition. Allergies, including specific reactions to each medication, such as rash and or nausea, must be recorded, as well as allergies to foods, insects, or environmental factors. Note: tobacco use, including type type cigarettes, are often reported in packed years. A person has smoked 1.5 packs a day for 2 years has an 18 pack per year history. If someone has quit, not for how long. Okay. This is the way in which we collect the history of the patient. History. Now, note tobacco use, including the type, okay, that's in alcohol and drug use, should also be investigated and is often pertinent to the presenting illness. Past history, childhood illness. These include measles, rubella, mumps, whooping cough, chickenpox, rheumatic fever, scarlet fever, and polio. Also include many chronic childhood illnesses. Adult illness. Provide information related to adult illness in each of the 4 years. Medical illnesses such, such as diabetes, hypertension, hepatitis, asthma, and human immunodeficiency virus (HIV), hospitalization number and gender of sexual partners, restricting risk taking sexual practices. Okay. Surgical dates, indication and types of operations of obstetric and gynecologic, obstetric history, menstrual history, methods of contraception and sexual function, psychiatric illness and time frame, diagnosis, hospitalization and treatments. Health maintenance. So, cover stated aspects of health maintenance, especially immunization and screening tests. For immunization, find out whether the patient has received vaccines for tetanus, pertussis, diphtheria, polio, measles, rubella, mumps, influenza, varicella, hepatitis B virus, human papilloma virus, meningococcal disease, Haemophilus influenza, type B pneumococci, and herpes zoster. For screening test, review tuberculin tests, pap smears, mammograms, stool tests for occult blood, colonoscopy, and cholesterol test together with results and when they were performed. If the patient does not know this information, written permission may be needed to obtain prior clinical records. Family history. Under family history, outline or diagram the age and health of or age and cause of death of each immediate relative, including parents, grandparents, siblings, children, and grandchildren. Review each of the following conditions and record whether they are present or absent in the family: hypertension, coronary artery disease, elevated cholesterol levels, stroke, diabetes, thyroid, or renal disease, arthritis, tuberculosis, asthma or lung disease, headache, seizure disorder, mental illness, suicide, substance abuse, and allergies, as well as symptoms reported by the patient. Ask about any history of breast, ovarian, colon, or prostate cancer. Ask about any genetically transmitted diseases. Okay. So personal and social history. The personal and social history captures the patient's personality and interest, source of support, uh, coping style, strength, and concerns. It should include occupation and the last year of schooling, home situation, and significant others. Sources of stress, both recent and long term, important important life experiences such, such as military service, job history, financial situation, and retirement, leisure activities, religious affiliations, and spiritual beliefs, and activities of daily living ADLs. Baseline level of function is particularly important in older or disabled patients. The personal and social history includes lifestyle habits that promote health or create risk, such as exercise and diet, include including frequency of exercise, usual daily food intake, dietary supplements, or rest or restriction and use of coffee, tea, and other caffeinated beverages, and safety measures, including use of seat belts, bicycle helmets, sunblock, smoke detectors, and other devices related to specific hazards, include sexual orientation and practices of and any alternative healthcare practices. Avoid restricting the personal and social history to only tobacco, drug, and alcohol use. An expanded personal and social history personalizes your relationship with patient and builds rapport. You will learn. Okay, fine. Okay. So, hard examination checklist. Meet your patient and introduce yourself. Wash your hands. Give the patient correct position and while examination. Start with general inspection to assess shortness of breath, dyspnea, sign of any pain, pallor, diaphoresis. Inspect the patient's precordium. Inspect the neck for visible carotid pulsation. Inspect the patient's precordium for the apical impulse. Palpate the carotid artery by placing your index and middle finger on the carotid artery in the lower third of the neck for assessment of a carotid artery. Palpate the apical impulse (PMI) with the pads of the fingers. Describe the locations, diameter, and direction of PMI. Palpates S1 and S2 by firmly placing the right hand on the precordium. Palpates S3 and S4 by applying lighter pressure at the cardiac apex. Palpate the thrills by pressing the palm on the precordium. Palpate the hips and lifts by with the finger pads on precordium. Palpate left ventricular area, finding vigor of LV. Sorry. Okay, guys. Okay, guys. So that's it for today, and thank you. Bye. Pranay, I will solve it out in class. Okay. Bye bye.